Moving forward, our next speaker for today, we have Dr. Nitin Samil Raju. It's my privilege to welcome our esteemed speaker, Dr. Nitin Sir, a Doctor of Pharmacy graduate from East Point College of Pharmacy, Rajiv Gandhi University of Health Sciences, Karnataka. He is currently serving as a clinical pharmacist at Believers Church Medical College Hospital, Tiruvalla, where he specializes in medication optimization, evidence based pharmacotherapy, and patient counseling for autoimmune and rheumatological conditions. Dr. Nizin's academic and professional journey is marked by notable achievements from authoring multiple research publications in reputed journals to organizing CARECON 2024, the annual state conference of the Indian Rheumatology Association. He has also conducted impactful health awareness seminars, prepared antibiograms for hospital use, and been a finalist in state level badminton tournament apart from his academics. His dedication to advancing clinical pharmacy, research, and community health makes him an inspiration to young healthcare professionals. Today, so we'll be delivering on the topic what are the roles and responsibilities, also the challenges of clinical pharmacists in clinical immunology. Please join me in welcoming Dr. Nijin Sir. Welcome, sir.
Thank you. Thank you so much for that kind introduction. Before we begin, can you please confirm if my audio is clear?
Yes, sir, it's clear. You can go ahead.
Thank you. Thank you for the response. First and foremost, I'd like to express my gratitude to our Master of Ceremonies for the warm welcome and to all the participants joining us this evening. Truly appreciate you taking the time out of your Saturday night to be here. It's so wonderful to see so many pharmacy professionals, so many medical aspirants who gather to explore the evolving role you play in clinical immunology. To know more about clinical immunology, I look forward to sharing some kind of overview or insights and engaging you all with this section. Moving on to the topic, clinical immunology. Before we wrap up, I'd like to say that clinical immunology is an incredibly vast and dynamic subject with layer of complexity from basic immune pathways to advanced therapeutic strategies. My goal today was to give you a specific overview on the most clinically relevant aspects, so you have a strong base to explore further. So, what is clinical immunology? Immunology is an ever-evolving field that sits at the intersection areas of fascinating field. Through, I will walk you through the core concepts of clinical immunology, including its foundation, immune mechanism, disorders, and our role, clinical pharmacist's role in clinical immunology, especially through the lens of a clinical pharmacist. I will try to share my screen now. Hope everyone can see the screen.
Yes, sir, it's visible.
Thank you. So, clinical immunology, a rapidly evolving frontier. Let's start with the basics. Clinical immunology is the study of disease that arise due to malfunctioning of the immune system, whether it's become overactive, as in autoimmune disease, or underactive, as in immunodeficiency disease. It involves the diagnosis, monitoring, and management of immune-mediated disease through a multidisciplinary approach, where clinical pharmacists play a growing role. Move on to the overview of immune system. The immune system is our body's defense mechanism. It is divided into major two arms. First one is innate immunity, which is our non-specific first-line response, and adaptive immunity, which is specific and forms memory against particular pathogens. Let's break this down in detail. Innate immunity. Innate immunity is our body's natural defense present from birth. It acts immediately and non-specifically. Some of its major functions include acting as the first line of defense, activating cytokines and the complement system, promoting phagocytosis, and serving as a bridge to activate the adaptive immune system. There are some components of innate immunity which consists inside the innate immunity. First one is anatomical barriers. These are the both anatomical and immunological barriers. First one is anatomical barriers includes mechanical elements like skin, mucous membrane, and cilia. Then the tears, saliva, and peristalsis that flush out pathogens, which acts as a immune system in our body. Then comes chemical barriers, which include lysozyme and phospholipase in tears and saliva, fatty acids in sweat, low pH in gastric secretion. These are the defensive and surfactants that have direct antimicrobial effects. Together, these prevent pathogens from entering or colonizing in the body. Next one is immunological barriers. Immunologically, the innate system involves phagocytic cells like macrophages and neutrophils, natural kill cells, that is NK cells, which target virus infected and tumor cells. These natural killer cells have specific as antigen antibody bond which destroy the specific virus infected or tumor cells. Next, coming to the complement system, protein cascade that enhances optimization and pathogen destruction. Then there is cytokines. This helps to signaling protein that modulate immune response. Unlike innate immunity, this response is highly specific to antigens, develops slower, and forms long lasting memory, making future responses faster and stronger. Next is adaptive immunity. Adaptive immunity is further classified into humoral immunity and cellular immunity. Humoral immunity mediated by B cells, which produce antibodies, and for cellular immunity mediated by T cells, including CD4 helper T cells, which coordinate immune responses, CD8 plus cytotoxic T cells, which directly kill infected or abnormal cells. Then comes antibodies, different antibodies which is present in the human body. Uh, Now let's briefly look at the antibodies, also known as immunoglobulins, produced by B cells. First one is IgG, most abundant long-term immunity crosses placenta. Next is IgA, found in mucosal secretion, saliva, and breast milk. IgM, first responder during infection. Then IgE, involved in allergies and parasitic infection. Then the last one is IgD, least understood, involved in B cells. It's also found in B cells. Each types plays a important role in the immune system. Next is how innate and adaptive immunity interact. So key part of immune response is how innate and adaptive immunity communicate. Antigen presenting cells, that is APCs, examples like dendritic cells, macrophages, capture pathogens and present antigens to T cells, activating adaptive immunity. This crosstalk ensures a tailored and efficient immune response. Next is different autoimmune diseases. When the system misfires, autoimmune disease occurs when the immune system fails to differentiate self from non-self, attacking its own healthy tissues. There are some common examples for autoimmune diseases. First one is rheumatoid arthritis. The target tissue for immune rheumatoid arthritis are joints. It always affecting the joints like DIPs, PIPs, like small joints. Specifically, it attacks small joints. And the immune mechanism which act on rheumatoid arthritis are RF, anti-CCP, and T cell activation. The next autoimmune disease is SLE, systemic lupus erythematosus. Target tissues are multi-organs like skin, kidney, etc. The immune mechanism involves ANA, anti-DS DNA, immune complexes. Anti-DS DNA is the major biological markers for detecting SLE. Next immune autoimmune disease are psoriasis, target tissues which affects on skin. The major also already driven by IL-17, interleukin 17 and interleukin 23. Next one is type 1 diabetes, also an autoantibody autoimmune disease, affects on pancreatic B cells. The immune mechanism involves autoantibodies, cytotoxic T cells. Next one is Hashimoto's thyroiditis. Target cells are thyroid, and immune mechanism which affects Hashimoto's thyroiditis are anti-TPO, anti-thyroglobin. These are the biological markers which used for finding anti-Hashimoto's thyroiditis. Next one is ankylosing spondylitis. Target tissues are spine and sacroiliac joint. The major biological markers are HLA-27, TNF mediated inflammation. Then comes the diagnostic tools in clinical immunology. First one is ANA, anti-nuclear antibodies. ANA tests are the major diagnostic tool for detecting several autoimmune diseases. ANA consists of two types of tests. First one is ANA immunofluorescence assay. This is the first primary biological markers for detecting autoimmune diseases. First one is IFA, which detects the how many auto antibodies are present in our body. If it's one, if more than one or two, it resembles like one plus or two plus or three positivity. There is one more ANA test which is used for detecting autoimmune antibody, that is ANA profile. In ANA profile, it shows specific autoantibodies which causes several disorders like SLE, rheumatoid arthritis, and Raynaud's phenomenon, etc. Next is anti-CCP, mainly for rheumatoid arthritis, HLA-B27 for ankylosing spondylitis, ESR-CRP. These are the information markers also used as a biological marker for rheumatoid arthritis and SLE. Clinical relevance of immunology. So why is clinical immunology important today? Because immunological disorders are chronic, progressive, and often life-altering. And with the rise of biologics and targeted therapy, the role of clinical pharmacists is expanding. We are now directly involved in selecting appropriate immune targeting drugs, dilution and preparation of biologics like secukinumab. Secukinumab is a drug, it's a modified drug mainly used as a interleukin 13, mainly acts upon interleukin 13 cytokines, which modulates the psoriasis and then the Behçet disease and Sjogren syndrome, etc. Educating patients on safety, injection technique, and infection prevention. Monitoring response using tools like DAS28, BASDI. These are the tools mainly used for checking the severity of diseases like rheumatoid arthritis. Next one is clinical pharmacist roles and responsibilities in clinical immunology. First one is therapeutic expertise. Recommend appropriate immunomodulators, biologics, and DMARDs. The first and one of the most crucial roles of clinical pharmacists in clinical immunology are therapeutic expertise. As clinical pharmacists, we serve as a critical link between immunological science and practical pharmacotherapy. Our expertise lies in selecting the most appropriate medications based on specific immune disorder, disease activity, and organ involvement. Also, check on the patient-specific factors like their comorbidities and lab result. We guide the use of conventional immunosuppressants such as methotrexate or azathioprine, biological agents like TNF inhibitors, and newer targeted synthetic DMARDs such as JAK inhibitor. The goal is to tailor therapy that is not just effective but also safe, sustainable, and evidence-based. In therapeutic expertise, understanding the mechanism of action of each class is a key. For instance, TNF alpha inhibitors like adalimumab target pro-inflammatory cytokines. We have to understand the mechanism of action for TNF alpha inhibitors like adalimumab. Then interleukin 17 blockers such as secukinumab are more specific for diseases like psoriatic arthritis and ankylosing spondylitis. Then comes rituximab, which targets CD20 on B cells, especially used in conditions like rheumatoid arthritis and certain forms of vasculitis. Then comes JAK inhibitor, which act at intracellular signaling level, are useful when biological fail or are contraindicated. We also contribute to personalized medicine by interpreting biomarkers and pharmacogenetic data. For example, anti-CCP and RF levels help guide RA treatment. And then ANA and anti-DNA titers are vital in like detecting systemic lupus erythematosus. For SLE, we can be majorly checking ANA and anti-DNA whether how much the titer, according to the titer, we will check the severity of the SLE in that specific patient. And then HLA-B27 positivity may also support early biological intervention in axial spondyloarthritis. Beyond drug selection, we help develop stepwise treatment strategies, starting with conventional DMARDs and escalating to combination therapy or biologics when needed. We also support tapering decisions when patients enter remission, reducing unnecessary exposure and costs. There is bridging therapy and step-by escalation. Pharmacists help physicians to start steroids as induction or bridging therapy while waiting for DMARDs to take effects. Concurrently, like with DMARDs, we also start to give corticosteroids to give a specific instant initiation in the medication or management for specific autoimmune disease. Then escalate from monotherapy to combination DMARDs or to biologics. Then we taper the corticosteroid dose gradually during the remission without rebound flares. Next, then comes therapeutic updates and guidelines. Pharmacists stay current with international guidelines like EULAR, ACR, GRAPPA, AS. EULAR is the European Association of Rheumatology. They like according to their protocol, we are giving the selective management for the autoimmune diseases. New approvals, biosimilar updates, and comparative trials, clinical evidence on switching therapies or dose spacing for safety and cost efficacy. They often brief clinicians during immunology boards or drug review meetings. For example, a 45-year-old woman with moderate rheumatoid arthritis with uncontrolled on methotrexate. First, we give immunosuppressant like methotrexate, then also their RA is become still on flare. Then we gradually get into the next step. The clinical pharmacist recommends adding adalimumab, a TNF inhibitor, confirms that TB screening is negative. Why we are screening TB before initiating adalimumab? Adalimumab is a TNF inhibitor where TNF alpha is a cytokine which is responsible for controlling latent TB infection in a human body. So when we act upon TNF alpha inhibitor, the TB bacteria become reactive and it becomes active TB. So before giving adalimumab, we have to screen TB. We have to make sure the TB is negative and we can give the adalimumab for further management in rheumatoid arthritis. Also advises steroid tapering once biological takes effect. Once adalimumab take effects, to reduce the flare of rheumatoid arthritis, we have to think on the steroid tapering to avoid long-term adverse effects. Next is medication safety and dosing. In the field of clinical immunology, where immunosuppressive and biologic therapies are central to treatment, ensuring medication safety and correct dosing is critical. Clinical pharmacists are uniquely positioned to anticipate, prevent, and manage medication related risks that can have life threatening consequences if not addressed proactively. The first subtype of medication safety and dosing, ensuring safe initiation of therapy. Before starting immunomodulatory or biologic therapy, clinical pharmacists must screen for some contraindications like TB, which we already discussed regarding the screening of TB before giving JAK inhibitors or TNF alpha inhibitors. And we have to check hepatitis B before initiating TNF inhibitors. Review baseline blood works. We have to check the total count, the liver function test, renal function, and lipid profile. So why we are checking on renal function is before we starting methotrexate, immunosuppressant methotrexate, we have to screen the renal function because around 80 to 90 percentage of methotrexate is excreted unchanged via kidney through glomerular filtration and active tubular secretion. So it will result in the risk of toxicity, which leads to the accumulation of methotrexate in the kidney without excreted through the urine. So methotrexate toxicity can leads to for certain immuno baseline workup. That's why we have screened LFT, renal function, and lipid profile. Next one is identify immunization gaps. Live vaccines should be given before immunosuppression. Check for active infection and latent conditions like CMV or EBV in transplant settings. These steps ensure the patient is in a safe baseline state to start therapy without risking reactivation of infection or serious adverse effects. The next subtype is dosing adjustment based on patient factors. Clinical pharmacists tailor dosing by evaluating renal and hepatic function. Example, methotrexate requires dose reduction or discontinuation in renal impairment because the excretion of 80 to 90% of methotrexate is done in kidney. So if any disorder is happened to kidney, so the excretion and it won't be actively happen. So it will result in the risk of toxicity. Also, it will result in the accumulation of methotrexate. Then comes the leflunomide may need caution in hepatic dysfunction. Why lefno is contraindicated in irregular liver function tests. If liver function is deranged, it won't eliminate leflunomide. Same as leflunomide is excreted through liver. So if any impairment is happened in liver, the accumulation of lefnomide will happen and leads to the toxicity of lefnomide. Then comes age and body surface area, especially in pediatric or geriatric patients. According to the body surface area and age, we have to dose calculate for methotrexate and for adalimumab as well as cyclophosphamide. Weight-based dosing for certain biologics, example infliximab. Disease activity and response over time. Proper dosing avoids under-treatment, disease progression or over-treatment, toxicity. Drug drug and disease interaction. Clinical farms actively monitor for major drug interaction. Example, methotrexate plus NSAIDs, which increases the risk of toxicity. Methotrexate toxicity. JAK inhibitors plus CYP3A4 inhibitors. Example, ketoconazole. Disease state interactions like avoid TNF blockers in patients with heart failure. Use caution with JAK inhibitors in patients with VTE, venous thromboembolism risk or malignancy. Why JAK inhibitors is a risk in VT or malignancy patient. JAK inhibitors can affect cytokines that is responsible for the regulation of platelet production. Then specifically JAK2 inhibitors, particularly associated with erythropoiesis and thrombopoiesis. They update the prescribing team in real time about potential risk and recommend alternatives or adjustment. Next comes dilution, reconstitution, and administration guidelines. For biologics, pharmacists provide step-by-step dilution and reconstitution protocols according to the EULAR. Example, secukinumab. Secukinumab is an IL interleukin 17 inhibitor administered subcutaneous, comes as lyophilized powder, reconstituted with sterile water and gently swirled, not shaken. Final concentration depends on strength. Example, it comes under formulation of 150 mg per ml. Administration route and side guidance. First one is IV infusion versus subcutaneous infusion versus oral agents. Rotating injection sites, managing infusion reactions or pre-medication needs. The other one is preventing and managing adverse drug reactions. We are trained to identify early signs of serious adverse drug reaction, neutropenia, hepatotoxicity, infection, TB reactivation, anaphylaxis. Next one is implement risk mitigation strategies, periodic lab monitoring, co-prescribing gastroprotective when needed, pre-infusion hydration or histamines, maintain adverse event documentation and pharmacovigilance report. The other function is tapering and discontinuation strategies. Pharmacists help design tapering protocols to prevent withdrawal flares when stopping corticosteroids or biologics, guide slow monitor discontinuation when patients reach clinical remission, adjust timing of interrupted dose due to surgery or infection. For example, a patient with psoriatic arthritis is started on secukinumab. So we have to review renal function, confirm TB testing, and ensure immunization are up to date. Provide exact reconstitution protocol to the infusion needs. Instead the patient on correct injection site, rotation, and storage. Schedules regular CRP and CBC monitoring as well as ESR levels and follow-ups to detect any early signs of neutropenia or infection. The other major role is monitoring and assessment. Monitoring and assessment are foundational responsibilities of clinical pharmacists managing patients with immune-mediated disorders. Given the chronic nature of autoimmune disease and complexity of immunotherapies, continuous evaluation is necessary to ensure treatment goals are met and adverse events are prevented or promptly addressed. First one is disease activity monitoring. Clinical pharmacists routinely monitor disease activity to determine if current therapy is effective, if dose adjustment, switching, or escalation is needed or not, if remission or low disease activity has been achieved. They interpret validated clinical scoring systems such as for rheumatoid arthritis, there are monitoring tools like DAS28, CDAI, SDAI. DAS28 is a software where we enter the patient's where if the patient's having any pain in the DAP or PAP joints, we have to enter how much tender joints and how much swollen joints are there. And according to the level of CRP, based on ESR level, we have to check through whether the patient is in the remission period or the current therapy is effective or not. Next one is for psoriatic arthritis, PASDAS, DAPSA, and one more is there, NAPSI, where we evaluate the nail deformities. Next one is axial spondyloarthritis, BASDAI and ASDAS. Measure axial symptoms, fatigueness, and stiffness and inflammation. For systemic lupus erythematosus, we have SLE-DI, BILAG, multisystem involvement and organ damage. Then comes the vasculitis, BVAS. It has a systemic inflammation and organ-specific involvement. These are the monitoring tools which we use mainly for clinical immunology. Clinical pharmacists calculate this cost during each visit, or whether the patient having any flare or the patient having any remission. It document trends and provide them to treating physician according to the remission or according to the flare of the patient. The EULAR protocol will give the step-by-step management, whether to initiate biologics or to initiate JAK inhibitors. Next comes laboratory and biomarker surveillance. Frequent monitoring of lab parameters is necessary for evaluating drug efficacy. Example, to check the level of CRP, ESR for inflammation. Then detecting early toxicity, assessing organ function. Through the help of TDM, therapeutic drug monitoring, we have to check the early toxicity of certain drugs like methotrexate, cyclophosphamide, etc. Whether the patient is having any toxicity or they also affecting any organ function or monitoring parameters are CBC, which detects leukopenia, anemia, thrombocytopenia. For liver function test, identify hepatotoxicity, especially with methotrexate and leflunomide. Then renal function required below or while on methotrexate or cyclosporine. For lipid profile, baseline and follow-up for JAK inhibitors. Quantiferon TB, testing for biological safety, auto antibodies. Example, ANA, anti-dsDNA for track SLE flares and treatment response. Then there is monitoring for adverse effect and complications. Clinical pharmacists are trained to detect, prevent, and report infection signs like fever, cough, dysuria, especially under biologics or steroids. Pulmonary toxicity, example, methotrexate. Hematological toxicity, azathioprine, cyclophosphamide. Neurological effects, long-term corticosteroid. Metabolic abnormalities, when JAK inhibitors applies, the high chance of elevated in lipid profile. They educate patients to recognize early symptoms and seek prompt care, improving outcomes and reducing hospitalization. Then comes response-based therapy modification. We play a vital role in adjusting therapy based on clinical response, escalating from conventional demands to biologics, switching biological classes if primary or secondary non-response occurs. Example, TNF, IL, interleukin 17 inhibitor. De-escalating therapy in remission to reduce long-term risk, managing drug holidays during infection, pregnancy, or surgery. These decisions are supported by clinical assessment, lab data, and standardized disease activity scores. Drugs like tofacitinib cannot be given during pregnancy period because it crosses the placental barrier, which may cause risk to the fetus. Next is patient-reported outcomes, that PROs, and quality of life. Pharmacists assess and document fatigue, pain levels, mobility, and mental well-being. Medication adherence and reasons for non-compliance. Daily functional limitations. Example, morning stiffness, hand grip in rheumatological. They incorporate PROs into treatment evaluation and share insights with physicians to optimize care. PRO. Patient-reported outcomes are there are several forms which is provided by the EULAR, European Association of Rheumatology, to check or to clarify or to assess the pain level of patients which is under the treatment for rheumatoid arthritis. Example scenario like a patient with rheumatoid arthritis on methotrexate and adalimumab is followed monthly. The clinical pharmacist calculates DAS 28 with the help of ESR and CRP level at each visit and orders CBC and LFT every 4 weeks to monitor safety. Notes rising CRP and increasing joint pain despite therapy, flags this to the patient. This clearly indicates the flare up of rheumatoid arthritis. So we have to definitely shift the management of rheumatoid arthritis. Then a support switch to a second line biologist. IL-6 inhibitor based on disease activity, trend, and system. Then there is the fourth cornerstone of clinical pharmacy involvement in clinical immunology is patient education and counseling. This role is not just about dispensing information. It's about truly empowering our patients to take control of their health, understand their disease, and engage in their treatment journey with clarity and confidence. Exploring this deeper, first we begin with the disease education. Many patients are newly diagnosed and often overwhelmed. Autoimmune diseases are complex, chronic, unpredictable, and sometimes multisystemic. We, as clinical pharmacists, take the time to explain what the diagnosis actually means. We break down the medical jargon into simple terms. What is happening inside their immune system? Why is the body attacking itself? The why the body is attacking its own healthy tissues. What is a flare and what does the remission looks like? For example, in patients with rheumatoid arthritis, we explain that unchecked inflammation can gradually erode joints and that early treatment is essential to prevent irreversible damage. We have to explain the importance of checking ESR and CRP to detect the inflammatory disorders in our own body. This may lead to identify crucial disorders like rheumatoid arthritis or Sjogren's syndrome. Next one is medication counseling, which is one of our strongest domain. We educate patients on the purpose of each medication, how it works at the immunological level, how long it may take to see result. For example, methotrexate can take 4 to 6 weeks to act upon in the body and to see the action of methotrexate, to see the result. Why adherence is crucial, even if they feel well, what side effects to expect, and how to monitor for them. Let me give you a practical scenario. When initiating a patient on secukinumab, that is interleukin 17 inhibitor, we guide them on proper subcutaneous injection technique, site rotation, and safe storage at 2 to 8 degrees, and what to do if they miss a dose. We also educate them on signs of adverse effects. For instance, when to report unusual fatigue, fever, or rash, the risk of infection is another critical area for counseling. Most immunosuppressive and biological agents reduce the body's ability to fight infection. We must ensure our patients are aware of early signs of infection. They need to avoid live vaccines. Whenever they are on any biologicals or JAK inhibitors, they have to avoid live vaccines because there may be a counter interaction in the body. The importance of routine immunization like influenza and pneumococcal vaccines, because we know autoimmune disease where in clinical immunology, our own immunity fights our own health tissues. So we have to control by we have to skip we have to skip the infection part where we have to take vaccines to prevent infection, and we have to vaccines like influenza and pneumococcal. Practicing good hand hygiene, avoiding raw or undercooked food, because through consuming raw and undercooked food, there may be chance of getting infection, and being cautious in crowd for high risk settings. This proactive counseling prevent hospitalization and keep our patients safe. And also, we educate patients on the benefit of anti-inflammatory diets rich in whole sugar, fiber, and omega-3 fatty acid. Regular physical activity to reduce stiffness, improve joint function, and boost our self mood, weight control, especially in conditions like psoriatic arthritis and SLE. Managing stress and sleep, as both can influence disease activity. The avoidance of smoking and alcohol, which can worsen symptoms and drug metabolism. These discussions shows patients that they have control over more than just medication. They can influence their outcome through daily choices. Then comes safe medication handling and storage. This includes correct storage of biologicals like adalimumab or infliximab, usually in the fridge. The ideal temperature is 2 to 8 degrees Celsius. Safe disposal of needle using sharp containers, handling hazardous oral agents like azathioprine we care, especially for pregnant caregivers. Such instructions improve safety both for patients and those around them. One of the most meaningful contribution we can make in empowering patients through shared decisions making. Then comes infusion service and biological handlings. Biologics have revolutionized the management of autoimmune and immunological disorders like rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease, and systemic lupus erythematosus, and many more. Many of these agents are parenteral, IV or subcutaneous, and require strict handling, preparation, and administration protocols. Clinical pharmacists play a central role in coordinating infusion services, overseeing biological storage, preparation, dilution, and administration, and also ensuring patient safety, educating both staff and patients. First one is coordination of infusion services. Clinical pharmacists work with rheumatology, immunology, gastroenterology, and infusion. You have to schedule necessary and management infusion appointment. Ensure timely procurement and availability of biologics. Confirm pre-medication requirements, example antihistamine and corticosteroids. Review clinical appropriateness before each infusion, that is lab values, infection status, previous infusion reactions. Maintain cold chain protocols for transport if needed. For example, coordinating an infliximab infusion for a Crohn's disease patient and ensuring the dose is adjusted based on trough levels. Then safe handling and storage of biologics. Biologicals are temperature sensitive protein based therapy, often requiring refrigerated storage and strict aseptic preparation. Pharmacists have to ensure proper refrigeration, that is 2 to 8 degrees Celsius. It has to be never frozen. Minimal light exposure for light sensitivity products like rituximab. Product integrity, no cloudiness, discoloration, or particular matter. Inventory is managed with first expiry, first out FEFO methods. Special handling notes for rituximab, infliximab, tocilizumab, and abiracept must be prepared under sterile condition. Some biologics must not be shaken to prevent denaturation. Strict attention to compatibility and dilution protocols. Example, saline only dilutions. Avoid co-administration of biologics with restore solution which may cause protein aggregation. Then comes biological preparation and dilution. Reconstitute biologics using manufacturer-specified solvents. Examples, sterile water, preservative-free saline. Use aseptic technique under a laminar airflow hood. Class 2 biosafety cabinet. Follow dilution chart carefully. For example, infliximab diluted in 250 ml normal saline, infused over 2 hours. For secukinumab, drawn into a pre-filled syringe or pen, administered subcutaneously. That we can counsel the patient to take self. Prepare medication just in time to avoid wastage of costly drugs. Example, preparing secukinumab in the record of 150 mg dose using two pre-filled pen or syringes for 300 mg weekly for 4 weeks. Suggested loading dose followed by the monthly maintenance. Then comes infusion reaction prevention and management. Biologic infusions can cause acute hypersensitivity or delayed infusion reaction. Farmers can help in screening for risk factors, example, previous reactions, allergic history, ensure availability of rescue medications like epinephrine, antihistamine, corticosteroid, guide pre-medication protocols if needed, establish infusion escalation protocols. Example, slow rate initially increases if tolerated. Train nurses on recognition of mild, moderate, and severe reactions. Record and document adverse events in pharmacovigilance system. For example, a patient receiving rituximab is pre-medicated with paracetamol and an antihistamine. The pharmacist remains on standby during the first hour of infusion. Then comes patient education and support. Pharmacists play a critical role in preparing patients, explain what to expect during the infusion. Example, time, possible reactions, monitoring. For example, patients are having ongoing infusion of rituximab, they may experience tachycardia, that we have to counsel the patients before they are getting ready into the infusion of rituximab. Teach early signs of hypersensitivity, flushing, chest tightness, itching. Provide information on subcutaneous option if the patient prefer home administration. Clarify timing, missed dose, and storage requirements for at-home injectables. Example, teaching a patient how to self-inject adalimumab safely and rotate sites weekly. That brings us to the end of my presentation for today's session on clinical immunology. I hope insights were informative and give you clearer understanding of how our role as clinical pharmacists is expanding within the important specialty. Now, I'm happy to open the floor for any questions, reflection, or comments you may have. Please free to ask the questions regarding clinical immunology.
So there are some questions asked by audience, like what are the latest advancements in immunomodulatory and biologic therapies for autoimmune diseases?
Yeah, a good one. Currently, we are working upon there are several articles which is published based on the CAR T cell therapy. We everyone know CAR T cell therapy in oncology. Just a minute, I will. Am I audible? Hello.
Yes, sir, you're audible.
Yeah. In oncology, we everyone know aware of CAR T cell therapy. Currently, there is a study ongoing, the same action of CAR T cell therapy in rheumatology, that is clinical immunology, for different autoimmune diseases like rheumatoid arthritis or Behçet or Sjogren's syndrome. It mainly acts upon B cells. In oncology, the tumors which is acts based on the T cells phenomenon. So the CAR T cell therapy modulates the T cell and the occurrence of tumor will minimize. The same like the CAR T cell therapy will act on the B cell, which responsible for the action of rheumatoid arthritis or Sjogren's syndrome. So CAR T cell therapy in clinical immunology is the current latest guidelines.
Thank you, sir.
Hello? Uh, Hello?
So there is one more question. How can clinical pharmacists best monitor and manage adverse effects of biologics and monoclonal antibodies? Like how can they manage adverse effects?
Biologicals and monoclonal antibodies such as like TNF inhibitors, interleukin 6 blockers, and how to transform the management of autoimmune and inflammatory disorder. Like how we can decrease the adverse effect by checking the vaccination status. We have to check whether the patient is having already took the vaccines for pneumococcal or influenza, because for if the patient is not having any like uh, specific vaccines, we have to check for TB screening before before we planning for biologics. We have to check TB screening whether some patients may have like latent TB inside their body. So whenever we started on giving whenever we start on giving biologicals, we have to check whether the patient is having any latent TB inside. So we have to screen for TB. The test name is quantiferon TB Gold. And if the patient is having, it comes in positivity, so we can give biologicals to the specific patient. So there are drugs like adalimumab. It's a TNF alpha inhibitor. So TNF alpha is responsible for the controlment of TB in a human body. So whenever we giving TNF alpha inhibitor, so it will inactivate. So it have a chance of reactivation of TB in the specific condition.
Hello, sir.
Hello.
Sir, I'm Mandira, a pharmacy second year student. And my
Okay.
question is, how can clinical pharmacists effectively collaborate with immunologists and rheumatologists, sir, in patient care teams?
Clinical pharmacist can be a key partner in the multidiscipline management of patient. So, like before clinical visit, we can review the patient's medication list for drug interaction, duplication, or any adherence issues. And also, we have to check the CBC's liver function test or renal function. And during consultation, we have to join consultation. We have to observe symptoms, side effects, or disease activity, or also co-develop treatment plans for rheumatoid arthritis or as well as psoriatic arthritis. Provide evidence summaries from ACR or European League of European Association Rheumatology. We have to check with our consultant, like rheumatologists. We have to check CBC for every 4 to 8 weeks. We have to check for cytopenias. We have to check for liver function tests. And we also help to transition of patients from IV to subcutaneous biologicals. And for patient used to share electronic health records to document intervention. Also, hello, hello, hello.
If anybody have questions, you can ask. So there is one more question. Are there certifications or advanced training programs you recommend for pharmacists interested in immunology?
Yeah, there are certain board certification. There are certain certificates are there in clinical pharmacist in rheumatology. First one is for board certification. We all know BCPS in pharmacotherapy. Also, there are some specialty which taken in rheumatology and clinical immunology. Then EULAR. There is I already discussed about European Association of Rheumatology. There are so many online courses which is conducted by EULAR on rheumatic diseases. The provider will be European Alliance of Association for Rheumatology. Then there is ACR, American College of Rheumatology. They also conduct so many online courses, and there are certain of online education provided by the group of research and assessment of psoriasis and psoriatic arthritis.
Thank you so much, sir.
Thank
I think questions are over. The session was very insightful and informative. Your guidance will surely help future clinical pharmacists interested in immunology to apply practically. People like you are really inspiration to work in healthcare sector. Thank you so much, sir, for taking time out of your busy schedule. Once again, I thank from RX doctors and whole team. Thank you, sir.
thank you. Thank you for having me. Thank you.
Before concluding today's session, I would like to inform agenda for tomorrow. We have two speakers, Dr. Srinath sir, who will be joining from United States and delivering on the topic demystifying the role of data research analyst. And also we have Dr. Manuj Ashok Jaiswal, who will be talking on step-by-step guide and practical tips for establishing the sterile chemotherapy drug admixing unit. I hope all of you will join tomorrow. Thanks for joining and see you all tomorrow. Have a good day. Before, before leaving, kindly fill the feedback form.